Welcome to everybody who's out there. We'll be getting going in a few minutes. It's a few minutes before 12:15, and we'll give everybody a chance to get on, and then we'll get going. We'll wait one more minute and we'll begin. Okay, welcome to today's clinical conversation for MCPAP. These conversations usually take place on the fourth Tuesday of each month. And today's topic is MCPAP, Attention Deficit Hyperactivity Disorder, ADHD guidelines. And my name is John Strauss, and I'm the founding director of MCPAP. Usually Barry Savette is here, who's our medical director, doing the introductions, but he happens to be on vacation this week. And so I'll be monitoring the call today. A few housekeeping issues, just to make sure that, to tell you that the session is being recorded and will be available on our website. As well will a copy of the PowerPoint slides and a recording. And and it's on a website under toolkits and resources on the provider section. Jeff Prince, who's our presenter today, will be willing to stop for questions during the presentation, but though there will be time at the end. If you do have a question, please type it into the Q&A box. You can do in the chat box, but the Q&A works best. And at the end, we may be able have time to unmute you if you want to raise your hand and ask a question. There will be a brief survey following the presentation, and we always appreciate your feedback. So today, our presenter is Jeff Prince. He's an instructor in psychiatry at the Harvard Medical School in Boston, director of child psychiatry at the North Shore Medical Center in Salem, and the medical director for our Northeast Regional MCPAP team at the North Shore Medical Center. Dr. Prince is involved in research into the characterization and treatment of ADHD across the lifespan, as well as pediatric mood, anxiety, and substance disorders. He serves as a member of the board of the Children's Trust Fund. He earned his medical degree at Emory in Atlanta and did his psychiatry residencies at Mass General. He completed his clinical fellowship in child psychiatry at MGH and McLean, and he's board certified in both general psychiatry as well as child and adolescent psychiatry. He's a recipient of many awards and honors, including the Distinguished Laughlin Fellow for the American College of Psychiatrists. And in 2005, he was selected as one of the best doctors in America. He's co-author of more than 60 original articles, abstracts, and book chapters, and he's made more than 150 academic presentations. So with that, please welcome Jeff and take it away. Thank you.
Thank you, John, very much, and welcome to everybody. Thank you for making the time to be with us today. And again, I'm happy to take questions in the middle if there's something that, or during the presentation, if there's something that really stands out, and we'll aim to make enough time for us to converse about the algorithm and any other questions that you may have on your mind. So thank you. We're really going through, and this is a few years ago, we had presented the ADHD algorithm along with some of the other algorithms. We just wanted to go through again and then provide some updates and walk through this algorithm. The algorithms, the really intention behind the algorithms, and these come out of a group that John and Barry lead, that's made up of the really the core clinical staff for MCPAP in terms of child psychiatry. And we're really trying to aim the clinical guidelines for primary care physicians to guide the really recognizing that the burden on our primary care doctors is so extraordinary, especially in this era, and the really essential role that you all play in looking after the mental health needs of the kids and parents of our families in this Commonwealth. So we're really trying to guide the screening process, to offer suggestions about evidence-based ways to evaluate, in this situation, ADHD. We want to bring to mind different considerations for treatment planning, and then specifically offer guidance about the initiation, titration, monitoring, and eventually possible discontinuation of medication as a part of the overall treatment plan, in this case for ADHD. In terms of the substance of the guideline and really of the algorithm, again, our aim, and we've got asked for feedback from primary care practices, and we really are indebted to Heather Walter and her group at Children's because of the extraordinary work they've done and the interactions with pediatrics and child psychiatry, but really aiming to develop this in a way that's the most useful and supportive of what y'all are practicing in primary care every day. The algorithms are really intended to be able to be utilized in a very efficient and effective manner in regular primary care practices. We're really making the recommendations using really evidence-based and well-validated clinical scales that have been used both in clinical practice, some also in research, but that are available to be used in a not heavy lifting manner in primary care. And then we really want to, in terms of medication guidance, make suggestions that support really the first line medications in the treatment, in this case of ADHD, and really think in terms of all the different options that may be available either in your choosing or that the parents may come and ask about, which really would break down into stimulants and non-stimulants, and we'll have a little bit of an update about that towards the end. So the process of the development of the algorithms really was meetings and our MCPAP medical directors leadership team, the MELT group. Again, we utilized and started with the work of Dr. Heather Walter and her colleagues at the PPOC practices. And the first three guidelines were depression, anxiety, and ADHD. Applying the algorithms, again, it's really our intention at MCPAP to help provide training for the primary care providers in what are really evidence-based tools. And our intent is really to help really make the management, and by the management, I guess I mean the recognition, assessment, diagnosis, and treatment of these relatively uncomplicated forms of ADHD in the mild to moderate or maybe even marked range that appear to be really primarily helpful in primary care practices. We recognize that you all do that. We are also trying to, in terms of our own internal validity and reliability, help to standardize some of our consulting team recommendations and guidances, both in phone conversations and in face-to-face consultations. These algorithms, as we mentioned here, are probably not the best starting place for the people who have the most severe ADHD, or in this case, ADHD that may be highly comorbid or maybe have been treated through a lot of other means. That guidance hopefully would come from, and we'd be able to, although maybe you've experienced it's difficult to access, through child psychiatry. We really also want to encourage really the liberal use of MCPAP and our phone consultation, and when necessary, our face-to-face consultations. We've worked really hard, and John and Barry have, and Sarah and Beth have done extraordinary work to help us all work more fluidly and to make it hopefully more seamless for y'all to get the answers in a timely fashion, really the input and guidance that you seek. So in terms of the guidance, what we're really, again, trying to provide with ADHD is the screening for ADHD, guidance around diagnostic evaluation, treatment planning, and then initial selection of medication, if it's appropriate in the situation. And then again, really starting, titrating, monitoring, and then possibly seeing if it's time to discontinue or titrate down the medication. These algorithms really are utilized and based on measurement-based care. And what we're trying to do is we've chosen the tools that hopefully will be able to both engage the parent and the care provider in a mutual discussion, as well as the patient. And what we're trying to do is to provide a structure that's evidence-based, that can really guide the conversation across these different spectra of assessment or recognition, assessment, diagnosis, and treatment. And we're really aiming to share and develop a shared language for the patients and the providers. And a question here, is it possible to get a copy of these slides or have a way to save the algorithm for future reference? I believe they're available on the MCPAP website, and we could ask John. I'll defer to MCPAP in terms of whether you can download them or if they're downloadable. I don't know that, but I think that we are wanting to share these with you.
Jeff, they're definitely downloadable, and we've provided them also in a written form, which you can request through the website. And both the algorithm is, as well as a set of clinical pearls that goes along with each of the algorithms that help you make them more useful.
Great, thank you. So again, we're really trying to connect and bridge the families and the patients and the providers. And I just want to, really emphasize that for the families, not only, I think, just out of necessity or due to desperate measures, people really like their pediatrician. They rely on you, as you know. They know you. They're familiar with you. You're a known entity, and you're in a really high position of trust. Whereas those of us in child psychiatry, we're not known as well, and there's not as many of us, obviously. But you really can provide for the family with these structured tools a way to have this mutual language that can be, we hope, very helpful both in your care of them, and then if they need connection with psychiatry, that will translate to our work as well. Let's see. So let's see. Is this here? Yes. So so in terms of the measurements that we're going to utilize and structure around, we want to make sure that they're relevant to outcome. And just like the quote up here says, it looks like you're growing, we want to measure it and be able to document it and use the same ruler, if you will, over time in order to try to understand really the function of kids within their different domains of school, social, family, as well as their own social, emotional development. We want to use a tool that's sensitive to change, so we really capture what's going on, something that's relatively brief and easy to score. We want to use these tools at the appropriate intervals, and we want to be able to share this with the patient and family, and we can again anchor it back from where they began. So this is a extraordinarily full and busy slide, and what we'll do is just walk through this over time. And what we try to structure it is in a way with the primary care visit, and again, I've mentioned already, as you see down here on the bottom, this was really based on the work of Dr. Walter and her group, and I want to just acknowledge that and the support that they had from the Department of Mental Health in developing this. If we go up and we look at these different parts of this evaluation, the first part is around the primary care visit, and a broad tool that's used is really the pediatric symptom checklist that Michael Murphy has developed and has a lot of validity in terms of a screening tool. And then if the screening tool is positive from the PSC, then what we can do is really do a brief clinical interview focusing on really the impairment and the distress that these symptoms are causing, right? In the guidelines that we provide from these screening tools in the brief clinical interview, if it seems subclinical, then the proper procedure is really self-guided or guided self-management and monitoring. If it seems that it's a problem that's impairing function, then what we want to do is a more focused assessment. So those are really the two of the main parts in terms of looking at ADHD. And if the screening tool and the brief clinical interview reveals really concern for immediate danger, or somebody's out of hand, or there's concern about that for things that are dangerous to themselves or they're so impulsive that they're really not able to safely participate, then we want to recognize that and refer either to reach out to a crisis team or refer them to a hospital, or when necessary, an emergency room for an emergent psychiatric assessment. Yes.
Sorry to interrupt, but you may want to advance the slides because we have a comment that it's hard to see on these, but I think in fact, if you go a couple slides down, we augment the, yeah, there you go.
Oh, all right. All right, sorry, okay. I apologize. Yeah, this will be a lot easier to see. I apologize about that. So again, this, if we look at, we're just looking for a screen, and we use the PSC, which has a cutoff point. And again, if there's a positive screen for ADHD, what we want to do is that brief clinical assessment in terms of looking at impact. And then certainly if there's concern for imminent danger, we're going to refer to the hospital. It's also might be a time, if there's not imminent danger or urgency, to either to reach out to MCPAP and discuss your observations and concerns with one of the child and adolescent psychiatrists, which is really what our CAP acronym means here, child and adolescent psychiatrist. Here is the pediatric symptom checklist. It has 17 items, and they're really ask these questions on a never, sometimes, often scale. And they're symptoms of inattention, and internalizing symptoms, symptoms of that are externalizing, as well. On the A scale, a score of 7 or more is considered positive for ADHD. And these are the scales that, these are the symptoms that include fidgeting, not able to sit still, daydreaming, difficulty concentrating, acting as if driven by a motor, and distracted easily. And any answer in the never category gets a score of 0, sometimes equals a 1, and an often equals a 2. And so if the score from these A categories, these items, 5 items really is 7 or more, that would be considered a positive screen for ADHD on the PSC, and that would trigger us to go on to a more a brief clinical interview, and this actually, it looks like it walks through these different, and then after the brief clinical interview, if there's concern, what the scale that we use are either the Bannerable Diagnostic Rating Scale. This is in the public domain. Nobody makes any money off of this. It's a little longer, and it gives more information. It queries more questions. It doesn't take too long. It's available both in English and in Spanish. And John, I'm not aware that it's in other languages right now, but I know it's in both English and in Spanish. And we'll give a more detailed assessment for ADHD to complement the clinical interview. In terms of looking at the scoring for this, the behaviors are counted if they have either an often or very often rating. And in terms of looking at inattentive subtype of ADHD, what we would need is to have 6 or more items on the 1 through 9, and that would be on these items right here on the Bannerable. And then the hyperactive impulsive subtype, okay, would be on the items, if it was focused on items 10 through 18, okay? And then if you have a combined subtype, what you'll need is 6 or more behaviors between each on both, or really on both the inattentive subscale and the hyperactive impulsive subscale. So these first 18 questions are really getting at the DSM-5 diagnostic criteria for ADHD, and they've been really measured and validated. We look for, the Vanderbilt also queries about a number of other types of things. So it queries for oppositional defiant disorder, and this requires a positive screen would be in 4 or more items in 19 through 26. Conduct disorder, 3 or more of the items between 27 and 40. And just to look at these are behaviors that include bullying, fighting, physical fighting, lying to obtain goods, skipping school, being cruel to people or animals, stealing things, deliberately destroying others' property, those kinds of things, staying out without permission, running away, those kinds of things are going to count under the conduct disorder screen. And then also gives a screen for anxiety and depression. And in these items, 41 to 47, it really asks about anxiety, fearful, worried, do new things, or feelings of worthlessness or being inferior, blaming yourself, feeling lonely, sad, unhappy, self-conscious, or easily embarrassed. So it gives a screen for mood, but it doesn't ask specifically about things such as suicide or psychosis. So the things that we want to really consider within these the Vanderbilt include other important rule outs. So we want to, doesn't query specifically around normal grief and loss. And certainly we see many of our population, our kids that are presenting really have the ACEs, the adverse childhood events and the impact of those, as well as things like death, divorce, and disappointments. So the normal bereavements. It doesn't really query for bipolar disorder in particular, or really for mixed mixed mood disorders that might be a result of activation from antidepressant medications or the combination of trauma and antidepressants. It doesn't query for medical disorders, or as I mentioned, the reactions to medicines, or for substance use. So these are some of the limitations of the Bannerable that are important to consider in your clinical or with your clinical eye. When people are, and the kids are more in the teenage years and really 12 or older, we like to use the SNAP, and that's this Swanson, Nolan, and Pelham rating scale, which again is more focused on ADHD and has very much the same 18 questions that are the first 18 questions in the Vanderbilt rating scale. But these are the two rating scales that we encourage or really use, will give guidance about using for our assessment of ADHD. In terms of, again, there are two subsets of symptoms. The first 9 items are involved in attention. The next 9 items are involved in both hyperactivity and impulsivity, rated on a 4-point scale. And this scale, the column here is going to represent 0 in terms of adding the score. Just a little is 1, quite a bit is 2, and very much is 3. So the highest score would be 54. And what we want to do is, this is a scale that we've used in research as well as in clinical practice. It's very sensitive to changes and can be used to really guide our treatment. And again, in the treatment of ADHD, which we'll mention, really involves both or not both, but involves the elements of psychoeducation, involves psychosocial treatments as well as medication treatments. In terms of looking at the different subsets, okay, a score of less than 13 is considered not clinically significant for the inattentive subset and the hyperactive impulsive subset. 13 to 17 is mild, 18 to 22 moderate, and over 23 is considered severe. And in terms of having targets for treatment, what we're really trying to do is to help people's symptom reduction get so that they're under 13, so that they're in the not clinically significant range on the SNAP. In terms of the diagnostic evaluation, and again, this is going down a step in the very busy slide that John helped me get off of, which is helpful, is again, the rating scales for those under 12 is going to be the Vanderbilt, and we can use both. I showed the parent form, but there's both parent and teacher forms, and then we use the SNAP 418 in kids 12 years and older. A number of important things to keep in mind on the clinical and diagnostic evaluation are really listed here. And so again, suicidality. So that might include either, thoughts of death and dying, planning for suicide. It might involve non-suicidal self-injury, which we certainly see a lot of these days, and provides a challenge. And certainly a lot of kids, I would say in my experience, one of the vulnerabilities for the kids with ADHD, even mild to moderate ADHD, is in that transition from elementary school into middle school, or middle school to high school, or high school to college. Those are times where there's a lot of newness and the kids aren't as familiar with their supports. And I've seen a lot of suicidal ideation and self-injurious behaviors in kids with ADHD, not just in kids with mood and anxiety problems, but it can create a lot of stress. We want to also really consider cultural issues and the challenges that this may provide both in the assessment, and we want to certainly have a lot of cultural sensitivity and awareness in our assessment. The scores and the rating scales, both the Vanderbilt and the SNAP, have been studied in various populations really across the world. So we feel comfortable using it in our Commonwealth in terms of the different cultures and ethnicities and races that comprise our kids. We also want to really think about and consider trauma, because certainly trauma with some symptoms related, not even necessarily to PTSD, but it could be developmental trauma or psychosocial chaos, which a lot of our kids and families are growing up in now, may manifest symptoms that look a lot like ADHD, and but may be really trauma-based. So we want to consider that. Now, all that being said, kids that are traumatized also can get or have ADHD and need to be treated. It really is a matter of assessment, and that might be an area that you reach out for the help and support of one of the child and adolescent psychiatrists. Another aspect to consider, certainly in the 12-year-old group and older, but it could even be younger. We're seeing younger and younger kids, especially would be around misuse of substances. And this might include things as little as, if you will, caffeine, but certainly we see a lot of troubles with nicotine and people and kids with ADHD vaping, and they're at a much higher risk for this, but also other things such as alcohol and cannabis and others. So this really these are areas we want to keep in mind as part of the overall assessment. In addition, and in terms of keeping other things in mind, we certainly want to keep a variety of other things in mind, primarily mood disorders. So whether this represents major depression, possibly a persistent depression as a result of the impact of ADHD, or another consideration is, does this represent a demoralization as a consequence of ADHD or ADHD plus learning disorders such as executive function problems or more traditional verbal or nonverbal learning disorders? Might this represent sort of the particularly difficult to treat form of depression, disruptive mood dysregulation disorder, or DMDD? Might this represent a bipolar disorder? And certainly many people, especially in the prepubertal age group with bipolar, have been diagnosed and are comorbid with ADHD, but most people with ADHD do not have bipolar disorder. Other considerations really these days, or not these days, but just in general, are really the autism spectrum disorders. So we might, for instance, note that a lot of kids, we see a lot of kids in the hospital these days, born 27, 28, 29 weeks, and they have a lot of other learning problems, either specific math problems or math disorders, or executive function disorders, or possibly neurodevelopmental disorders, global delays or nonverbal delays or things of that sort. So we want, and a lot of inattention can go, and it can look like that. We also want to recognize that while treatments for ADHD may be appropriate and improve attention, that they're not going to fundamentally change, the treatment of ADHD is not going to fundamentally change a learning disorder, although it might help someone be more available to learning. Also want to consider medication-induced symptoms, which might be related to things such as treatments for asthma, for instance, or treatment for other things. Some kids maybe who need to be on steroids can have a syndrome that looks like ADHD. So these are all things for us to just consider. And this, again, may be, if you're having questions, a consideration for a conversation with one of our child and adolescent psychiatrists. So here's a question. So, and I'll go on backwards. It says, so it says, is the SNAP only used for diagnosis but not for follow-up? No, we can use it for both. It's very sensitive to change, and we've used it both in research as well as in clinical practice. So it's sensitive to change. I would say that I've not asked a lot of college professors to fill out a SNAP form, but I think that that's not unreasonable if they're interested. But I would say that mostly with the college age kids that I'm getting the ratings based on their completion or my observation. So we're doing those together. Let's see here. Again, so in terms of sort of clinical decision making, that goes back to the very busy slide. Again, in cases of really subclinical or mild, the proper guidance is really to just monitor and have regular follow-up. In moderate ADHD, or in cases where the self-management was not successful, then we want to consider either, certainly providing more psychoeducation, but also consider referrals for psychosocial treatments and to consider medication. In more severe cases and situations, we want to really enlist specialty care, again, child and adolescent psychiatry, either in consultative roles or referral and management roles until the patient is stable. In terms of just switching and hopping over into the medication areas, and we'll have a little bit of an update, but it seems, and our guidance here at MCPAP is to become familiar. There are a number of different delivery systems, but if we're trying to make the choices more simplified, in my mind, what we want to look at is recognizing, one is that there are treatments that are FDA approved in kids and in adolescents and in adults, and stimulants and non-stimulants. The stimulants are really going to show the most vigorous response and the quickest response on a time scale. The non-stimulants, which for some individuals may be the most helpful and best tolerated and preferred, maybe they're very appropriate first choices depending on the clinical situations, which again, you may have some questions about or we can get into talking about, but all of these are reasonable first line treatments. We do ask that if you have a child you're considering pharmacotherapy with that's under 6 years old, that you actually consult us just so that you have the backup and we can help you have a more solid foundation or enhance what is already a solid foundation in terms of using treatments in that age group in particular. Before using any medication, we really encourage that you get a certain history, and so a personal medical history or family history of cardiovascular troubles. And what we were looking for really is cardiovascular history of either arrhythmias or outflow problems in people under the age of 35. We're not really looking for atherosclerotic disease or myocardial infarctions in people over 35 so much, although obviously we want to know that, but we're looking for early onset troubles with hypertension or arrhythmias or passing out or fainting or those kinds of things, really sudden cardiac death. And I will just comment, although a couple of very large data sets really help provide us some reassurance that when used in regular doses, that the ADHD medicines and primarily the stimulant medicines are not causing cardiovascular problems in our patients and can be used safely. However, if there's ever a question, please feel free to have us involved. Other baseline assessments in terms of that history is certainly measuring height and weight and monitoring those, monitoring pulse and blood pressure. In most patients, the cardiovascular impact of stimulants in particular will be to increase pulse or blood pressure a little bit, maybe 2 or 3 beats a minute or several millimeters of mercury, but it doesn't really aggravate those measures very much. Certainly with some of the non-stimulants, hypotension with guanfacine or clonidine may occur, and that should be monitored. What we also want to do in terms of our own rating scales are have a baseline, either Bannerable or SNAP, and then what we want to do is measure it in 2 or 3 weeks after starting the medication. And then we use those rating scales as a way to titrate up the medication. We've just chosen here a couple of examples. There are many other things that might be reasonable to choose from. We suggest in primary care is that you become familiar with several of them and become familiar with their dosing, how they're available, how to administer, and then choose between them. Although it's beyond somewhat the scope of our conversation here today, it's important to realize that with the stimulants, although they share a lot of similarities in their pharmacodynamics in terms of interacting with the dopamine transporter protein, that in fact both that methylphenidate and amphetamine have variable effects, and just because one doesn't work or isn't well tolerated, the other might be. It's also important to remember, so it's very common in clinical practice to have a trial of a methylphenidate version and have a trial of an amphetamine version. Again, if that's, it depends a little on the willingness of the patient, but some people respond, many people, at least half of the people respond kind of equally well to either one, but some people seem to respond better to methylphenidate clinically and some better to amphetamine clinically. And actually, I'll just take a break from the medicine part, and there's an excellent question here in terms of some of the academic supports for people with ADHD and initiating a 504 plan or an IEP. So a couple of things is it's important to remember the difference between 504 plans, which is a federal mandate. So basically, 504 plans can occur in somebody when they have an appropriate medical condition, and and ADHD is amongst them. So if the family can get a 504 plan, a 504 plan will provide accommodations for the student in their usual curriculum. So it provides accommodations, not any modifications to the curriculum. So the public schools, and the standard in the Commonwealth is called FAPE, F-A-P-E, Free and Appropriate Public Education. So a 504 plan helps to provide accommodations so that that student can access their free and appropriate public education. These may include extra time, extra supports, organizational coaching, preferential seating, extra time with the teacher, those kinds of things. But the expectation is for the usual curriculum to be fulfilled. It usually requires a letter from either the primary care doctor or whoever's making the diagnosis, documenting that they're diagnosed with it and advocating for that. And then the school will can provide that. The school can respond by providing it and recommending testing, educational testing, or possibly neuropsychological testing. In terms of an IEP, an individualized education plan, that's under a different set of laws, and that's Chapter 766 of the Federal Code. And what that provides for access to free and appropriate educations or modifications to the curriculum. And that requires both a request by the family in writing to the school system, and the school system then has, I think it's 45 days to make an assessment. The school now can actually, it used to be the school could not say no. Now they can say no, but it can be appealed. And the IEP process can be a long and grueling process. And of course, these days, especially the schools have lots of big responsibilities to lots of groups, but those are the ways to get it started, is really to write a letter on behalf of the patient, documenting that they have ADHD and requesting either a 504 plan and or an assessment for an IEP. So hopping back to the medicine questions, we encourage, and we just picked these 4. These are approved medications. And just a note, in my practice, usually, you would pick a starting dose, and really, I don't increase it in more than weekly increments. Some people do it in 2-week increments, and you can do it in between by measuring the doses. But there may be clinical situations that it's appropriate to make the plan to increase a time even in between when you're measuring the Vanderbilt or the SNAP. But we're encouraging you to use that as your anchor rating scale. All right. Here's just a couple of updates, and really since we developed the things, and these are things that we don't generally recommend and are sort of beyond, but I wanted to put them in here just so that you might get questions from your patients about them. So there is now actually a device that was FDA approved in 2019. It's the external trigeminal nerve stimulation system. I would say that as of yet, and it's approved by the FDA to treat ADHD in patients 7 to 12 years old who are not taking ADHD medications. So far, it's not been supported by insurance companies. Of course, that could change. I have to say I don't have any experience with it. My colleague Jim McGuff out at UCLA did some of the work with this. And I'll just leave that at that. But just recently, earlier this month, Biloxacine, it's really the first medication treatment that's been approved in about 10 years. The most recent one was Intuniv, or extended delivery guanfacine. It received the approval as a treatment for ADHD in patients between the ages of 6 to 17. Biloxacine was used in Europe for a number of years as an antidepressant medication. So like other antidepressants, it does carry the black box warning for increase in suicidality in children. I have no experience with it, but I just thought you might be interested to hear about it, and you might receive questions about it. So I'll just leave it at that. So in terms of managing the medicines, certainly after the adjusting the dose, we want to measure the Vanderbilt or the SNAP. And we want to really start to both ask about tolerability as well as changes in score around different domains. And we can titrate up the medicine every 2 to 3 weeks towards a maximal goal. If the maximal therapeutic dose is reached and the improvement's not sufficient, then we might either think about a consultation with one of our child and adolescent psychiatrists, or consideration of just a different type of treatment. Once we have the treatment in place, we recommend on maintenance scheduling, monitoring every 3 or 4 months, looking for safety, tolerability, effectiveness, and also possibly for signs of remission. We want to query specifically about adverse effects, most importantly probably around sleep, appetite, weight, and also things such as substance use or misuse and use of other things such as nicotine, cannabis, alcohol, or others. Once we have a treatment, we want to find out, because a lot of the impact of ADHD is contextually dependent. So there are a number of patients that actually benefit, and it's appropriate to have them not take it on weekends, holidays, or vacations, but it may be. And so that's a conversation and a dialogue to have that's individualized for each patient. Again, if there are questions, our child and adolescent psychiatrist can certainly answer the questions. We ask that you consider titrating off at the end of the school year, although many patients really benefit from continued treatment across the entire year, because ADHD is not just an in-school difficulty, but it's also reasonable to consider titrating down. This is a great question. Do I recommend a baseline EKG for everyone? And the answer is no, and neither does the American Cardiology Association recommend this. What we do is, if there's a family history of early onset, again, before the age of 35, or there's symptoms in the patient, a change in exercise tolerance, fainting, palpitations, those would be indications to get an EKG, but I don't recommend either for stimulants or non-stimulants that they get an EKG at baseline. So in terms of psychosocial treatments, there are a number of guidelines for psychosocial treatments, and these are some of them. One is to provide a structure and a system for behavioral modification. We also want to often improve parent guidance, both for the child, and it's also important to realize is that ADHD is highly familial and largely genetic, but not entirely genetic. And often helping a parent who has ADHD, if there's a child with ADHD, there's a good chance that there's more ADHD in the family tree, and sometimes getting the parents directed towards treatment can be very helpful. And we recognize that in primary care, mostly you're not treating the adults generally for this, but may refer them, hopefully. We certainly want to improve and enhance communication within families in terms of the structure and their communication. You know, ADHD can be very difficult, and it's often described as sort of not a problem of knowing what to do, but a problem of doing what you know. And help parents have a consistent parenting approach can be very important and helpful for the child or adolescent. Another area that we might consider is really around school consultation, and in fact, we have some pilot projects through McCap. They're making ourselves available to some of the schools, but certainly consultation with y'all in the schools could be helpful. And then there's a lot of great information from organizations, either such as McCap or the American Academy of Pediatrics or American Academy of Child and Adolescent Psychiatry, to provide excellent psychoeducation for families. So in terms of the applications, again, the algorithms are really intended to help guide treatment around the mild to moderate or the subclinical cases, in cases where there's lots of comorbidity or people aren't responding as well or not tolerating the medication. Please feel free to reach out to us so that we can provide supports either from a in-person consultation, or these days, I guess, a lot of virtual consultation, or a phone conversation, or possibly both. So thank you very much for your attention and participation today and making time. I really, again, just want to say thank you for all that you do to help look after the kids in our Commonwealth. Thanks.
Jeff, thanks a lot. We do have a few other questions that come in, and we have about 5 minutes. So maybe we had a question from Sue Fan Lin about a video game she mentions in Deer Rocks. Do you have any comment about those kind of programs to help kids with ADHD?
Well, I think there's a lot of interest both in terms of using video as a modality to try to help with ADHD. I'm not familiar. I have to confess, I don't believe that they're really in the mainstream of training. I think people also try to have used a video platform for other things such as depression and trying to apply CBT kind of modules. People have used trying to help with executive functions in terms of some video, in terms of helping improve working memory and possibly processing speed. A very interesting idea, but it's not something I generally recommend. And in fact, most of our kids with ADHD spend enough time on video, so I'm not using it as a augmentation strategy generally.
Great, thank you. Maybe could comment, we suggest for the mild kids that parents may use guided self-management. What do we mean by that?
So what we mean by that is for the parents really to learn as much as they can about ADHD and maybe get some parent guidance, maybe through a psychologist or a social worker or through their school, in terms of the way they structure their home or the way they respond to the child, both in terms of parenting, but also giving guidance. And there's certainly excellent information from some parenting organizations such as CHAD. So it's really trying to apply either psychosocial treatments or psychoeducation on their own or with guidance from the primary care.
Okay, and I think we have Linda Cohen comments that there are a number of books specifically to help children with understand their ADHD symptoms. I don't know if you have any particular recommendations or.
Usually I just have people look at either the AAP or ACAP websites, and I do like the CHAD website and the sort of the ADHD warehouse. There's a lot of good information. I refer people to those quite frequently, and they can look through and kind of find ones that appeal. I haven't found one that's sort of the best for everybody.
We also had a question from Hey Yankolev about can that be an EPIC? Can the SNAP be an EPIC? And I think that needs to be something that you talk with each of your systems, because every system has its own EPIC. But certainly that would be helpful.
Yes.
And particularly for both the Vanderbilt and the EPIC, the Vanderbilt and the SNAP, to have those in a patient portal so the family can complete them or would be helpful. But that's again something you need to talk with your own system about.
And those are yes, we've had those. That's a great idea, and we fully support it. Maybe your experience is like mine. Getting something into EPIC often results in epilepsy. So.
Okay. Let's see.
So here's a question. Somebody asked if somebody should have a formal testing to confirm the diagnosis. So I think that ADHD is really a clinical diagnosis, and it does not require neuropsychological testing. It can be done by a primary care physician, a psychiatrist, a psychologist, and it's really putting the clinical symptoms and their impairment and ruling out things that also might be contributing. But I don't believe that they need a neuropsychological or educational testing. If there's concerns or when there are concerns around either executive function problems or learning disorders, that's the role that educational testing and neuropsychological testing play.
Jeff, we had a question here about just a comment that most people use the medicine but don't go very far with therapy. And I might just answer that we've had some studies, we've studied that it's mostly at the beginning of treatment, that if the kids who get both some therapy around orientation to the illness and to the treatment, along with the prescription, that do better in terms of adherence to the medication long term. So getting some counseling at the beginning and adjusting and having a more detailed analysis of how the family is coping then might happen with you as the physician. So that's just a suggestion that at the beginning, there's good data that getting therapy along with medication produces better long-term adherence to medication.
And I would say, John, I'll comment on that. It certainly is true in the younger kids. So in the PATH, the preschool ADHD treatment study, parent guidance really resulted in 50% effective treatment for the kids. And so especially in the younger age group, it's that parent guidance. So it's either not so much with the kid as it is with the parents. I would say in the MTA study, what we learned is that for about a third of the kids with ADHD, the medicine, sort of with or without other things, seemed to be really the key ingredient. But that leaves 2/3 of the kids who really need those other contributors. And that those were the kids who had other things going on, especially anxiety, that psychosocial treatments or psychotherapies were helpful. And certainly, as you mentioned, psychoeducation and some therapy about understanding how their brain works really helps improve adherence over time with all of the treatments, educational, medical, and social.
Okay, I think we've run out of our time, so I really thank everybody for their participation and their questions. And Jeff, thank you for a great presentation. And next month, our presentation will be on depression. And for some of you, this will be a review, but being that it's one of the more common disorders we're dealing with, I think it always helps to think about it again. So we'll look forward to you on the fourth Tuesday in May. Have a great day, everybody.
Thank you very much.